Good afternoon, everyone. Our case protocol is all about acute otitis media. Let's start with the subjective part. For the general data, our patient's initial is EM, a 10-year-old male who was born on November 10, 2008. He's currently residing in 773 Leo Street, Santa Mesa, Manila. He's a natural-born Filipino. For the chief complaint, for the dental part, his only complaint was his teeth were dirty and he wanted to be clean. For the medical part, he said that there's a discharge on my ear and it's painful. Now for the history of present illness, which is the dental. When the patient was 10-year-old, the patient is a 10-year-old male who wanted his teeth to be clean. 2 months prior to consultation, the patient was brushing his teeth and he noticed some black lines on the occlusal surface. He asked his mom what they were and his mother did not reply. No dental intervention was done because it was not painful. 1 month prior to consultation, the patient noticed the black lines were getting bigger. The patient wanted it to get fixed because he knew it was not normal. No dental intervention was done due to scheduled conflicts. Now for the medical part, the HPI for the medical part, the patient has known case of allergic rhinitis and history of acute otitis media, suppurative, as who came for an ear discharge of 2 weeks duration. 2 weeks prior to consultation, patient noted to have nasal congestion and sneezing. This was then followed by ear discharge on the left ear, described as white, thick, inconsistency. And then the mother also noticed presence of blood discharge. This was associated with itching of the ear, no pain noted, no medications was given. Patient was brought for consult for persistence of symptoms. For the past dental and medical history, for the medical history, patient has not sought any prior consultation. But for the medical part, positive intussusception, 4 months of life, repair at UERM, mumps, and allergic rhinitis since 2018. For the family history, no known diabetes or hypertension to the family. Now for personal and social history. First, personal and social history, the patient's house is in Bulacan and well-spaced, well-ventilated, non-congested. Patient's house in Manila is also well-spaced, well-ventilated, non-congested, but outside the house, it was foul-smelling because a neighbor raised chickens. Okay. For the review systems, in general, there's negative weakness, fatigue, fever, or weight loss. There are no rashes, itching, dryness, color, scabs, sores, lumps, change in hair, no head injury or lightheadedness, no eye pain, redness, excessive tearing, double blur, none of those. No problems with the ears, throat, or neck. The breasts are also normal. And then for the respiratory, negative cough, dyspnea, wheezing, and pleural pain. No heart murmurs or any type of heart trouble. For the gastrointestinal, the appetite is good and no nausea, vomiting, indigestion. Bowel movement about once a day through sometimes 2 to 3 days. Normal peripheral vascular, muscle, bone, joints, and legs. And there's no signs of depression or any psychiatric disorders. Doesn't really bleed and no signs of anemia. And then for the general appraisal, patient was awake, alert, conversant, and non-cardiorespiratory distress. That's your name. Thank you. Objective ka. Wait, this is something. It's stop. Now let's go to the objective part. Now let's go to the objective part of this case. Now first is general appraisal. The patient was awake, alert, conversant, and not in primary respiratory distress. He was well responsive and talks in an orderly manner, and he was cooperative, responsive, and he behaved properly. The patient was able to ambulate without any assistance needed. He was well dressed for the weather and properly groomed. No signs of distress noted. For his vital signs, since he's only a kid, we didn't get his blood pressure at all. His temperature at that time was 36.6 degrees Celsius. He stands tall, about 158 centimeters, and he weighed 32 kilograms. His BMI was 14.3, which is considered normal. His pulse rate was 75 beats per minute, and his respiratory rate was 22 beats per minute. For the extraoral examination, his face is symmetrical, no TMJ clicking sound, no swellings, his lip is normal, and his lymph nodes are not abnormal. For the intraoral exam, he has fair oral hygiene, pink color of the firm gingiva. He has caries in some of his teeth, normal tongue position, and he has a class 1 molar relationship of occlusion and has a straight facial profile. During physical examination, his skin was warm and dry to touch, no rashes and scars. For the head, his hair is of average texture, scalp without vision, and he has a normocephalic or atraumatic head. For the eyes, vision is 20/20 in each eye, visual fields full by confrontation, pink conjunctiva and white sclera. Pupil constriction is normal, round, regular, equally reactive to light. This margin sharp without hemorrhage and exudate. For the ears, patent ear canals, well curved vena. Quick recoil. For the left ear, AS. Left ear. Patent EAC, white thick discharge, positive hyperemic call not COL not appreciated. For the other ear, patent EAC, positive cerumen, intact TS, positive call, negative bleeding and negative discharge. There is intact gross knee. For the nose, septum is in midline, left turbinates with yellowish, both turbinates with negative nasal congestion, non-hyperemic, negative cobblestones, and negative gross deformity abrasions discharging. For the throat, there is no inflammation and post-formation. For the mouth, his oral mucosa is moist. Uvula is in the midline, tongue is in the midline. Grade 2 hypertrophic, non-exudative tonsils, negative tonsilopharyngeal congestion, negative hyperemic exudates are hypertrophulations and bleeding. For the neck, the trachea is in the midline, negative cervical lymphadenopathy, thyroid not palpable, not tender, negative. So for the assessment, dental, the diagnosis for the dental is multiple caries on the occlusal surfaces of the teeth. For the medical, acute otitis media, super acute. So, for the treatment plan,
which is the last part of the case protocol. Our treatment plans for patient PM, first for the dental plan, we should have a diagnostic plan, which is to take a very apical radiograph. For the non-pharmacologic plan, oral prophylaxis restoration on each numbers 1, 2, 1, 5, 1, 6, 2, 2, 2, 6, and 2, 6 in patient. For the pharmacologic plan, then there's no pharmacologic plan. For the medical non-pharmacologic plan, the patient should avoid ear manipulation, water precaution, have the child sit up, raise head on pillows or lie on unaffected ear, apply heating pad or warm hot bottle, and have the child chew gum or blow on balloon to relieve pressure. For the pharmacologic plan, oral toilet, start ciprofloxacin otic drops. And the first line of antibiotic therapy is amoxicillin, which is 80 to 90 milligrams per kilogram per day, divided into 2 daily doses for 10 days. Next is the journal.
So let's now move on the journal. Topic is allergic rhinitis and its impact on asthma. Researchers' objective to update their knowledge of allergic rhinitis, to highlight the impact of allergic rhinitis on asthma, to provide an evidence-based documented revision, diagnostic methods, to provide evidence-based revisions on treatments, and to propose a stepwise approach to management. Background of the study: allergic rhinitis is a symptomatic disorder of the nose induced after all allergen exposure by an immunoglobulin E or IgE mediated inflammation of the membranes lining the nose. It was defined in 1929. And then the 3 cardinal symptoms in nasal reaction occurring in allergy are sneezing, nasal obstruction, and mucus discharge. Significance of the study. So the ARIA document was not intended to be a standard of care document for individual countries. It was provided as a basis for doctors, healthcare professionals, and organizations involved in the treatment of allergic rhinitis and asthma in various countries to facilitate the development of relevant local standard of care documents for patients. So, methodology. So, the first questionnaires assessing seasonal allergic rhinitis dealt with nasal, catarrh, and runny nose during spring. So, questions introducing the diagnostic term of seasonal allergic rhinitis were successfully used. Have you ever had seasonal allergic rhinitis, or has a doctor ever told you that you suffer from seasonal allergic rhinitis? A score considering most of the features and allergic rhinitis, or the critical symptoms, season of the year, triggers, parental history, individual medical history, and medical history and perceived allergy has recently been proposed. The results showed that remission of allergic rhinitis symptoms was relatively infrequent, and that the remission of both symptoms of IgE and sensitization was rare. A study in Sweden showed that the prevalence of allergic rhinitis increased from 12.4% in 1992 to 15% in 2000. So the incidence of allergic rhinitis from 1992 to 2000 was 4.8%, while 23.1% of the cases with allergic rhinitis in 1992 stated no rhinitis symptoms. In 2000, indicating remission. After 10-year course of disease, 20% of patients with non-allergic rhinitis reported spontaneous disappearance and 36% improvement. So, allergic rhinitis is relevant to dentistry because it affects and alters. So the dental relevance to hospital dentists, allergic rhinitis so the dental relevance to hospital dentists, allergic rhinitis is relevant to dentistry because it affects and alters the child's growth pattern, causing changes in the adenoids, long face syndrome, and respiratory obstruction syndrome have been reported, which affect craniofacial development. So, these diseases are expected to result in reduced hypotonicity of the upper and lower lips, increase in incisor proclination, anterior open bite, and class 2 malocclusion. So, oral predisposing factors of TDI are inadequate lip coverage, increased overjet with dental protrusion. Consequently, the characteristics of soft tissue and malocclusion may be the reason for the increased risk of TDI in patients with allergic rhinitis. Thank you.